I'll show you first on the skeleton model, and then I'll show you on a person, and then we'll practice it together. So for this one, you're gonna put your patient in prone. You're gonna put like a little towel roll here, just so, because especially the kids, they hyperextend a lot, so then it's not an accurate measurement. So we're gonna put down hyperextension. We're going to find our landmarks first. So our landmarks are going to be the fibular head. We're going to find the anterior and the posterior fibular head. You're going to bisect it with a marker. I find that it's easier to find with a knee flexed. Like, so to put the tissue on a little slack, I find I can kind of mobilize it to confirm I'm on it. It's a little bit more posterior than you probably anticipate it to be. But before you mark it, put it back to straight, because the skin will move. So then you mark it. Then you're going to go to your lateral malleolus. So that's a pretty prominent bone, it's easy to see. Find the anterior and the posterior components and mark it. Then you're going to take a long straight edge. I like this one just because it's real long. And then you're going to draw a line just on the proximal or the distal 1/3. Here, that's going to be your proximal reference arm. It's a little easier visualization that way. Okay. The distal reference arm is going to be the plantar surface of the base of the fifth metatarsal. Okay. The axis is not going to be on the lateral malleolus like it is in the first goniometry class. What we're going to be more concerned about is lining the two proximal and distal arms up, and then wherever the axis falls, it falls. So it most likely will be distal and posterior to the lateral malleolus. So don't let that freak you out. The next thing we need to do is put the foot in subtalar neutral. So to put the foot in subtalar neutral, let's do this little activity on yourself. So you're going to find your anterior talar head. You can do it on the floor, you can put it up here. So it's right in the front. And I want you to supinate your foot fully and pronate your foot fully. Supinate your foot fully and pronate your foot fully. So when you supinate your foot, what do you feel? Do you feel something going to the lateral or the medial finger?
Lateral.
I feel medial.
Oh, wait.
Here, go on the floor. Okay. So feel it. Put a lot of pressure on your baby toe side. So, okay, on the medial side, you probably feel the anterior tibialis tendon. It's not a tendon you're feeling, you want to feel a bone. So the bone is going to be laterally. When you pronate the foot, you feel the bone come more medially. So that's what we're looking for on your patient. So then what we're going to do, we're going to put our patient in prone. If it's the left leg of the patient, I use my left hand to palpate anteriorly, and I use my right hand to move the foot. I fully supinate the foot, and I feel it come laterally. I fully pronate the foot, and I feel it come medially. So kind of how I envision it is if that's lateral, that's medial. I supinate, I hit the end point. I pronate, I hit the end point. Supinate, hit the end point. Pronate, hit the end point. I'm trying to find that arbitrary middle, like where it sits right in the middle. It's pretty tough initially, but it's just like a practice type of thing. I caution you not to just put the calcaneus vertically or put the Achilles tendon right in the middle. That's where it looks visually pretty, but that's not necessarily where the subtalar neutral is, especially our kids with atypical feet or low tone. So we're gonna do that, and then we dorsiflex the foot by loading it with the opposite hand. So it's left. I use my left anterior, and then a handshake grip with the right. So I put my thenar eminence on the 4th and the 5th metatarsals, and I dorsiflex the foot. So for R1, that's basically just taking up the slack. So it's almost like if you have a wrinkle in your t-shirt and you just make it flat. It's not really aggressive. What I usually tell you to do is look from the side then and see is the foot truly, because we're measuring dorsiflexion. So if we wrote, say, 5, I would assume that that person had 5 degrees of dorsiflexion. What is more common, especially in adults, is that we're lacking X number of degrees of dorsiflexion. So you want to take a step back and see, is it truly in dorsiflexion or is it in plantar flexion, and record it appropriately. And then when you go to do R2, you load it as hard as you can. If it's a little one, you have